Good morning, everyone, and welcome to Grand Rounds. In celebration of International Radiology Day, we actually have two of our own internationally renowned pediatric radiologists who are going to speak to us today, Dr. Dorothy Bulas and Dr. Raymond Z.
Well, thanks for coming in the kind of snow. So who knows what, I gave it away. So who knows what November 8th, 1895 was famous for? Just a shout out. You're cheating, but yeah. But for us, it is a very, very important day. It's a day that Wilhelm Röntgen accidentally detected electromagnetic radiation, and he was studying the effects of electrical currents passing through different gases. So we have been celebrating radiology and its discoveries for the last 5 years with what's called the International Day of Radiology. And this year it was on pediatrics. So we celebrated in our institution, we've celebrated in our city, country, and internationally as well. So we really had a very nice outreach throughout the world, globally, and we actually reached about 2 million people with our International Day of Radiology in pediatrics. So to celebrate that, we wanted to look at the past, talk a little bit about what we now offer at Children's in radiology, and then also talk about the future. So on the history and maybe the present, and then Dr. Z will be the future. So talk about translational research. Radiology X-rays were truly the fastest. He submits his manuscript December 28th, and he actually said as he submitted it, now all hell can break loose. And it was printed and distributed in 3 days. Let's talk to our other journals about this. And within a week, the Vienna Press took hold of this exciting discovery, Lancet Nature Science. They all embraced the idea of being able to look at the body with X-rays. So he presented this paper in January 23rd, so not even a month after it was published, and by the mid-1896, there were already radiology in practice, including fluoroscopy. He received the Nobel Prize, the first one in physics, in 1901. This is the first X-ray of a child. It's from 1896. It's a 3-month-old. It did take 14 minutes to get this beautiful image. Now, who in anesthesiology is here? Because this was great sedation. I don't know how, you know, we have problems with our MR and movement, but how they did it, I don't know. So it's a dramatic paradigm shift. So this X-ray was done also in 1896. It is a 13-minute exposure, but looks very similar to what we see in this day and age. So it really opened a new world of discovery. And the first radiology lab specifically for pediatrics was opened in Grasse in 1896 as well. There's been always a strong link between radiology and pediatrics. In fact, the first radiology book was written by Thomas Morgan Roch, and he was a professor of pediatrics at Harvard University and a pioneer of neonatal care. And we really deal with this day to day with our trainees. We struggle a lot knowing what normal is before we know what abnormal is. Now, John Cathey was a pediatrician as well. He became one of the true grandfathers of radiology, pediatric radiology. He was at Beatty's Hospital. In those days, actually, since there was no radiology department, the pathologist would run the lectures and review the cases, and he would always be in the back saying snide remarks. And finally, one day, the head of pediatrics said, "Okay, if you can do better, you do this." And he became the head of pediatric radiology, and his books are still used by all of us today. In 1957, our society was founded. And after that, X-rays were being used throughout hospitals, but also in department stores. Here on the left, these are X-rays to look at your foot, right? In Bloomingdale's, if you want to get nicely fitted shoes, you would get an X-ray to make sure they fit nicely. We'd also do X-rays of your head to see if your hat was fitting correctly. So, yeah, so X-rays were important, but ultrasound, CT, MR, nukes, and IR have all involved as well in developing diagnostic imaging and radiology, not just radiology. So let's talk a little bit about history of some of the other modalities. So this is actually an ultrasound. Now, I know most of you can't read ultrasounds now either, but I really can't read that one. That was actually a bladder. It was a first trimester pregnancy. This was initially developed by a Swedish cardiologist and Scottish obstetrician. And this was one of the first ultrasound machines, quite large, bulky, water bag, B-mode scanning, and you could barely see anything. So the evolution has been quite dramatic with ultrasound over the years. As you know, I'm very interested in field imaging, and this is a 3D rendering of a 14-week fetus. So our imaging abilities with our higher resolution transducers has allowed us to make quite amazing diagnoses, particularly in pediatrics where our children are smaller, thinner. We can get closer to the organs, and it's become a mainstay of pediatric imaging. Doppler has really helped. On the left, we see a picture of an appendix that's inflamed. On the right, this is called a B-flow image. It's a sagittal image of the neonatal brain. We can see not only the anterior cerebral artery, but many of the smaller vessels as well. We're also moving to use ultrasound in different modalities. We just started our elastography program with ultrasound, and what this does is tries to determine the stiffness of various organs, and we're initially using it for liver. The hope is that we can assess stiffness of the liver to and correlate it with the amount of fibrosis so we don't have to do biopsies as much. It's also being used for different tumors. Contrast ultrasound was finally approved this year, again, not quite ready for prime-time use in pediatrics, but we're hoping to utilize it to do reflex studies without radiation. It gives us some better information about tumors in different solid organs, and the hope is actually to be able to deliver some of our medications via these contrast agents as well. I think one of the biggest exciting areas of ultrasound is simply size. So here we were in the 1940s, this huge, bulky machine which showed images that no one could really interpret. Now we can move around with these, really see things quite exquisitely. But this was just shown in this year's RSNA. You can purchase a transducer now and hook it into your Android and scan. So this is truly going to be the stethoscope, I think, of the future. And I have to say there are 3 different transducers now that can be plugged in. This will eventually be compatible with the iPhone. And you can see quite, the resolution is really quite wonderful. Okay, let's move to neuroradiology. So Dr. Vizina and I are very glad we're not that old, because look at what we had to deal with as neuroradiologists in the past. They did pneumoencephalography. So this is looking at air in the ventricle, third ventricle, and cisterna magna. And that's what we could see of the brain. Not very exciting specialty at that time. But then CT was developed, and Hounsfield's pioneering research in the 1970s is arguably even a more important discovery than the X-ray with Röntgen. And on the left, we have one of the first pictures of the first head CT, and there was a lesion in the frontal horn here, and this is what the first CTs looked like. So present day, CT is still a real important mainstay of our department. We can see bones quite beautifully, do 3D rendering. On the right is actually a fetal CT of bones. With our IV contrast, we can see vessels exquisitely. We can see the airway. The lungs are very importantly identified by CT, and we can do with our 3D rendering with our powerful computers, look endoscopically. This is a trachea. There's now something called dual energy CT, where you can have basically 2 different KDPs. And what that allows us to do is look at the organs simultaneously at different KDP and MA levels. This dual energy allows us to look at arteries and veins at the same time, ligaments and bones, and different vessels. The other important thing that we'll talk a little bit about is the fact that as our vendors improve the resolution of CT, the amount of radiation needed for these amazing images has decreased dramatically. So I think now we've been a little bit nervous about using CT because of the radiation issues, but our newer vendor study modules have been able to get some of these studies done in less than 1 millisievert. MR is another great modality because it doesn't use radiation, and Purcell and Mansfield are considered some of the grandfathers of MR development. This is a picture of the first MRI scanner. And MR, I think, really revolutionized not just how we look at the whole body, but particularly in neuroimaging. And here, not only can we see the anatomy of the brain, but we can see some of the function with functional MRI. We can see areas of ischemia. We can see vessels without injecting contrast. It has really, I think, been quite incredible in its evaluation of DTI. Here, this is pyramidal tracts, helps the neurosurgeons to see where the tumor is in relationship to some of the more important nerve roots. MRI is also very important for musculoskeletal. All of you who are interested in sports and are limping, we always get an MRI for the knee or the hip, but it's really been used now to look at osteoarthritis, looking for infections. For the abdomen, we nicely see the biliary tree, the gallbladder. On the right, we have a cine image of bowel. We're now using MR enterography to look at our children with inflammatory bowel disease without any radiation. And for those of you who know me, I love fetal, and fetal MRI truly revolutionized fetography and the whole area of fetal imaging, as well as fetal technologies in doing invasive therapy for the fetus. MR can also be used as a lab. We're now using MRI to assess quantitatively how much iron is stored in the liver. We're now starting to be able to do fat quantification, and there is elastography by MRI that's available as well in some centers. Again, the same premise is to try to assess the fibrosis of the liver by imaging, either by ultrasound or MRI, so we don't need to use biopsies. Let's move on to nuclear medicine. So this is an image that Mr. Maj gave us. This was a brain scan done in 1969 at the Children's Hospital, even before CT. You can see this was a sparganosis, which is a parasite that they could visualize when we didn't have MRI or CT to take a look at the brain. Since then, there have been dramatic developments in nuclear medicine as well. We still use it routinely as bone scans or renal scans, and with PET-CT, the fusion of the fuzzy PET images with the CT or MRI images have, again, really revolutionized how we follow tumors and look for infections. Here we can see response to therapy with follow-up PET-CTs. And PET-MR is now available in various centers, again, trying to decrease the dose of radiation, and this was for a stereotactic biopsy of the brain. And now we're going to move from diagnosing to treating. We're going to do a shout out to interventional radiology, and some of our interventionalists are here. This is the first arteriogram. It's quite a beautiful image. It was done in 1896. They used a mixture of bismuth, lead, and barium salt. So the good news, this was an amputated hand, so we didn't have to worry about the toxic effects of it, but really the vessels are beautifully delineated. So that was the first arteriogram. And I have to say, I think interventionalists, like surgeons, you have to really be tough. So this is how they did aortographies in the 1920s. They did translumbar approaches. So they kind of harpoon a long vessel into the aorta, inject contrast, and then I don't know who took the needle out and why they didn't bleed, but it did work. This is a percutaneous transthoracic aortogram. This is from the 1930s, and Karun gave me these images. So So people were not too excited about getting these studies done, then they started doing some cut downs. This was via the carotid artery, and again, the images were as good, but probably a little bit safer. And then here's Karun, much more elegant nowadays. He may have a harpoon, but it's much more controlled circumstances. He can biopsy really anything that you need. And when we're looking at the vessels now with our catheters and small vessels and catheters, we're able to embolize, dilate, look at vessels quite beautifully without that morbidity mortality that occurred in the past. Not only do we look at vessels, our interventionalists will help drainage procedures with like biliary trees, as you see here. When there are obstructions in the kidneys, it can help place stents. So they've really become a very important part of the non-invasive therapies. And I just want to do a little bit of a shout out for the IGNITE group here at the Sheikh Zayed. So it's image-guided non-invasive therapeutic energy. So HIFU, I think we're one of the few pediatric hospitals that have HIFU, and this kind of uses some ultrasound techniques with MRI and intervention. So there's a low power sound waves that are generated by the ultrasound transducer, and it's focused. It can generate some high power and heat to the area. So it's multiple phased array transducers that are accurately focused to one area. And thermal tissue, there's a high temperature that can occur and can actually ablate and cause coagulative necrosis. And there have been 3 osteomas that have been utilized here using the HIFU BioFX, integrating it with the MRI. And again, without any radiation, we're able to utilize this for osteomas. And there I think we had one case who had a tumor for some treatment of pain management. So very exciting area of radiology. I initially did pediatrics, and I always am so thrilled that I was able to discover the dark of radiology. But there are so many benefits, but as you know, there are also risks. And practitioners, initially when this exciting modality came into play, had no concept of radiation safety. So here's a radiologist and the person who's getting the x-ray, and notice how the protective shielding is completely non-existent. So really within 3 months of the discovery, people started noticing that, hey, there actually were some side effects. And again, if Bloomingdale's again, getting your feet x-rayed and your head x-rayed, they noticed, gee, I was getting a sunburn being in Bloomingdale's, and my hair was falling out, and my eyes got a little bit bloodshot when I got that new hat, but it was transient. So here, with radiation, we do know there is something called direct deterministic effect, and with just direct radiation, you will get burning, you will get hair loss. This was after 40-minute exposure, but the hair did grow back, so big deal, right? Well, I found this fascinating. Thomas Edison, a genius, got very excited with radiology, and he designed the first commercially available fluoroscope using calcium tungstate screens. His assistant, however, Clarence Daly, died within a year from exposure to the fluoroscope. And he stated, I did not want to know anything more about x-rays. In the hands of experienced operators, they are a valuable adjunct, but they are dangerous, deadly in the hands of the inexperienced. And he abandoned his work in 1903. Unfortunately, not everyone abandoned the work, or fortunately. So does anyone know what they were doing here? This is 96 minutes of x-rays for this child. Why did they do that? Yeah, the thymus looked a little bit big on the x-ray, so they did this to shrink the thymus. And this is a little bit, unfortunately, closer to home. This was just in 2009. I don't know if you heard about the Cedars-Sinai issues. They were doing some studies with CT, and you may not see it that well, but there's actually a burn and hair loss to the skin of this infant, very similar to what happened to the boy 100 years prior. So there's been debate about whether radiation truly causes stochastic effects and whether at low thresholds there really is an issue. But we do know that in children there is no debate that there is increased radiation risk to children. They are more radiosensitive the younger they are, plus they have a longer lifetime to manifest potential radiation-induced injuries. So with the Image Gently campaign, it was really a public relations effort to let the public as well as referring physicians who are ordering these wonderful studies to be aware that there may be a cost. And one size does not fit all, that if we're going to be doing a CT, make sure that the CT levels are appropriate for a child. And you've heard me talk about Image Gently, and I think we're a great center who follow these mantras. We're always calling and asking, do you really need this exam? Is this something that should be done now? Should we wait? Is it the appropriate time? We make sure that we're using the lowest doses possible with our scanners and our X-ray equipment. We image the areas that only need to be imaged. We avoid multiple scans, and we work really hard to provide other alternatives such as ultrasound and MRI. So I'm very proud that the hospital has embraced Image Gently and making the pledge. And lastly, before we move to the future, I do want just to do a shout out on global outreach. So approximately 2/3 of the world's population lacks adequate access to medical imaging. And the WHO estimates about 4 billion live with widespread losses that could have been avoided or treated if radiology was available. And 1 billion of these are children. So even in high resource areas, even in DC, pediatric access to healthcare and imaging can be limited. Access to pediatric expertise can be limited. The understanding of Image Gently and image safety can be not as strong in adult institutions where they're not really thinking about pediatric issues. And of course, we're always fighting for more research time and money. So we formed the World Federation of Pediatric Imaging, hoping to promote pediatric standards globally, be an advocate for getting resource allocation for children, encouraging safety and radiation, which is quite important, and fostering collaboration and communication. So it is an uphill battle. I'll also be going to Ghana next week for 2 weeks. That's a country of 28 million. There are 80 radiologists there. There are no pediatric radiologists. And they're growing. They've purchased CTs, fluoroscopy, don't have any real idea about radiation safety. So we're going to try to go to these places and from the ground up educate people on what are unique issues to the child. And this is a shout out for the Global Health Initiative that's being run now at Children's. I think March 2nd is going to be the inaugural special interest group. So all of you that are interested in this, please remember to include pediatric radiology as part of this initiative. And there's an ebook because of the International Day of Radiology that has about 40 different authors. It's free, it's downloadable, it's useful for your families who are asking for questions, but also for you. It has different chapters on the various modalities and different diagnoses, and I think you might find it very interesting. So now we're going to move to the future with Dr. Z.
Great, thanks so much for being here. So Dorothy kind of laid the foundation for the past and the present, so I have the distinct honor of sharing with you the future, both here and being created at Children's National. I'm going to cover 3 broad topics in sequence: environment, operations, and technology, and dig a little deeper. Each one of these is a multi-episode talk there, but environments that are part of healing for both patients and staff. I'm going to talk about the biophilia effect, storytelling, as well as on-stage and off-stage concepts. First and foremost, this is, as I think a lot of us recognize, the current state at many hospitals, and frankly, ours not too long ago. Why do I know that? Because this was our CT scan room, and this was our fluoroscopy suite. And I don't think there are a lot of children or families walking into a room that look like this that would think something good is going to happen to them in the next several minutes there. What is the biophilia stat? It's really simple and it's intuitive. Environments that are rich in natural views reduce stress and enhance focus. We are not that far removed from our primitive ancestors there. Particularly useful environments that require learning, healing, and concentration, and I think most of us agree that hospitals should be environments where learning, healing, and concentration take place. From this wonderful textbook written by William Lidwell, a design guru, here is a generic hospital hallway. We've seen these all over the place. Beige on one side, salmon on the other, not terribly inviting. The simple trick of putting in prints of a bamboo forest completely transformed the environment. We've really kind of taken this to the next level and have used nature to inspire, for example, our fluoroscopy suite up in Rockville. There are rocks, there are trees, there is grass, there is water, there are salmon leaping out of the water there. This is the design. How this actually translated in Rockville is pretty close to the original, and you can see there's water, there are shallow sandy bars that children skip along there when they get onto their whitewater raft. A friendly hippo wants to basically distribute an ore, and this really interesting ranger station is actually a view through which the technologist sees the child there. You are embraced by nature. What is storytelling? We all know what storytelling is, but those of us who have really looked into this, there are at least 6 distinct elements of storytelling. There has to be a time and place, characters you care about, a plot that ties those elements together. My favorite, though, is invisibility. That's where the medium disappears. When you are engaged and immersed in a book, you are no longer holding printed pieces of paper. You are in that area. You are caring and following your characters. The medium disappears. And obviously mood as well as a movement. So that's what a story is. Why is this relevant to a healthcare environment? We're trying to still tell stories in MRI. You are no longer getting an MR scan. You are going on an African safari. As you walk into our MR rooms, there are footprints leading you off to various directions. Off to one side, maybe there is an elephant family waiting in an oasis. Off to the side there, you see a mud-spattered Jeep as well as giraffes off there. You get it now. You are on an adventure. Surrounding you are pictures of tents with sleeping bags. Ah, I get it now. I've had a safari. Now it makes sense for me to lie still in this sleeping bag and lie in the tent for a little bit there. Scattered around the walls are pictures of djembe drums. So now I understand what that knocking sound is. It's not the gradient switching. It is people playing the djembe drums. You're surrounded by a story and hopefully distracted from the fact that you are sick in a foreign environment. On stage and off stage, what does this have to do with healthcare? Well, in a Broadway play, a production of Wicked, or your high school musical, there on stage is what we as the audience see. The characters know their lines, the costumes work, lighting is perfect, and the props don't malfunction. You are surrounded on stage by the story. Backstage, it is chaos. You've got costumes lined up, they're crowded, people are fighting, the Wicked Witch is getting her green makeup on, someone's having a temper tantrum, things are freezing out there, but the audience is spared from that backstage chaos. You want them to see things work well. What does this have to do with our radiology department? This is our new ultrasound suite. We call it PULSE, for Pediatric Ultrasound Scanning Excellence Center. Opened up just a few months ago. In this particular case, on stage, you are underwater. You're surrounded by the ocean. You have whales swimming both on the wall as well as on the floors there. The sonographer welcomes you on stage and takes you into one of our wonderful rooms. They're each one beautifully themed and crafted after a specific species of whale. This one's the beluga whale room. Our sonographers picked both the motif and theme, and we have beautiful original oil paintings in there. You do not feel you're in a hospital environment. The other thing you don't see, frankly, is what's going on backstage, and right behind a door there are our hardworking sonographers dealing with the daily chaos of our busy operation. There's a PICU patient who needs an ultrasound. There's an ED patient who's crashing. There are people asking her calls. It is not easy to handle our busy ultrasound service. But we don't want or need our patients to see that. We talk a lot about metrics, and that's how we improve there, but one metric that I shared with our faculty and staff was, this is what I want to be one of our metrics. I want a child, after having a study, to say, can I come again? Can you imagine that? And the amazing thing is within 2 weeks of opening our new outpatient imaging center, we did better than that. Not only does this child want to come again, he refused to leave after this fluoroscopy study. He had to be pulled out by his parents. That's environment. Let's talk about operations now. We want operations that are reliable, gentle, and wise. I'm going to talk about high reliability. I'm going to talk about imaging intelligently, and I'm going to talk about simulation training. We are leaders as an institution broadly in all of these domains there. Dr. Bulas mentioned this, but the radiology department is a potentially hazardous and dangerous place. We work with physics and phenomenon that can harm our patients and our staff there. This happened in 2001, a freak accident in Valhalla, upstate New York, where someone inadvertently brought in an oxygen tank in a rush to resuscitate the patient. That tank flew into the bore and killed that child there. I don't think that hospital has ever recovered from that, and certainly we wouldn't either. But again, here's a picture of an iron IV pole accidentally introduced in an MR environment and sucked into the magnet. Dr. Fricke, our MR physicist, estimate it was going about 300 miles per hour when it hit. Radiation dose, Dr. Bulas talked about this. I don't need to belabor this, except to give you a little bit more numbers. In 2009, over a period of 18 months, 1.5 years, about 206 patients got over 8 times the expected radiation dose there. Think about that. Why does this matter, particularly for our patients? This is our patient demographic, right? 0 to around 18 years old, and you can see the increased sensitivity, the increased risk to our pediatric patients when they're exposed to radiation dose you might encounter with an abdominal CT or a head CT. I'm going to talk about flying metal incidents as one of our major accomplishments here, and I have Dr. Fricke here to thank for this. In 2007, around the time he joined us, we had 48 flying metal incidents. Do the math there. That's 4 per month. Why? Our architectural design at the time pretty much reflected worst practices, and fundamentally we really had no formal MR safety. You read this paper, but really in terms of digging deep and teaching people how to be safe in the MR environment was not part of our culture at that time. 2012, 2013, a lot of hard work redesigning our MR suite. This is the old one, this is the new one. It's based on specific zones within MR. There are 4 of them. We use best practices based on the American College of Radiology recommendations, and Dr. Fricke went on a warpath, training about 100+ of our staff and faculty there. In those 2 years, 4 flying medical incidents. 4 per month in 2007, 4 over 2 years between 2012 and 2013. We were not content to stop at that. Given the heightened awareness and, frankly, terror of installing an interventional MR, we really ramped it up again. And basically at that time, Dr. Fricke went and trained about half of all the faculty and staff here at Children's. I've been told we have about 6,000 employees, positive 3,000 employee, faculty, and staff. Over 2014 and 2015, not a single flying metal incident. That's high reliability. How about imaging not just gently, but intelligently? And I'm very proud to be at an institution, including my colleague, Dr. Shireen Adabaki, who went out of their way to find ways to not do imaging studies. People are always worried about not doing CT scans and getting sued or the medical legal consequences and liability there. This group went out to see, can we not do head CT in certain patients who have had head trauma? And the bottom line, you ask 6 questions, find out 6 areas. Is the mental status normal? Is there no scalpel hematoma? Ask the parents, for heaven's sake. If it's no, 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 do not do the head CT. You will not miss a worrisome finding within the head CT there. This is licensed to do this properly. We have a wonderful simulation core there, and I just have to show this image. This is believed to be the first simulator in existence. So you are a knight, and you have been asked by your lord to train his son how to joust. Can you imagine the terror of having a young boy riding on a horse, galloping with a wooden lance, and thinking, gosh, you know, my lord's really not going to help me if his young son is skewered and killed. I better come up with a safe alternative, and this is it. It is a mannequin with a target. So the young lord races and hits that target. But he better pay attention because in this arm is a metal chain and a bunch of sandbags. It's not going to kill him, but boy, is it going to teach him a lesson. You have to be situationally aware. Hit that target, but guess what? The other person is trying to knock you off your horse too. Hit the target, avoid the target. Hit the target, avoid. The first simulation. How is this relevant to radiology? Well, there was a lot of concern at our outpatient imaging center about contrast reactions. Do we, as radiologists, know, despite our PAL certificate, how to recover a patient who's having an anaphylactic reaction? A lot of us were concerned, so we reached out to Lillian Sue and Heather Walsh. They came out and did a full-day workshop for us. Each one of us treated a number of patients, and this mannequin is phenomenal. I can't breathe. Ouch, is what it says when you actually give them the injection. Having saved multiple patients in the simulation, every single one of us, I believe, is quite confident now. So we have really ramped up the degree of confidence when patients with multiple allergies show up for a contrast-enhanced study. Okay, the last part I'm really going to kind of ramp up, and there's going to be a huge shout out to multiple members of the Sheikh Zayed Institute. Why? Because I'm going to tell you that not only is there a bright future, but we are literally creating that future. We're creating technology that increases sensitivity and specificity of both diagnosis and therapy for children there. We've talked a lot about CT, MR, ultrasound, nuclear medicine, and we constantly optimize and innovate within those domains, but I just want you to let you know that there are scientists hard at work pioneering alternate energies that might eventually, and I certainly hope so, will have a direct impact on patient care. What the heck is terahertz imaging? I'm not sure, but the frequency is so high that the resolution is practically histological. Now, for penetration, in terms of depth of penetration, it's only in millimeters, so you're not going to diagnose liver tumors. But look at this terahertz image of the skin. These are individual skin pores, and this is a subtle linear scar. Terahertz imaging might actually be a way in the near future to do non-invasive biopsy of skin and dermal lesions. Think about that for a second. 3D optical images, incredible volumetric and quantitative images of the back of the eye, the retina and the fovea. This is very exciting. Thermography, sensitivity to subtle decreases in or increases in temperature. This is a prize racehorse, got his injection in his shoulder there. This injection would be invisible given the imaging modalities available to us right now, but that subtle increase in temperature is clearly visible as a red blotch within this horse's shoulder. Why does this matter to us? You're in the emergency room. You have a child who's limping. Gosh, I just can't localize it. What we currently do is multiple plain films of the pelvis and the femur and the knee and the ankle and the foot, trying to find out where the pain might be. Imagine a future where the child gets a quick thermogram and the area of inflammation or injury is clearly demarcated by an area of increased reddish heat. I'm going to talk about quantitative imaging, and a lot of this is led by Dr. Mario Singararu in our lab with his wonderful, and I see Juan Cerralata in the back there. I'm going to give you a quick tour of history. Qualitative imaging is still much of what we do today. So if there's a child with inflammatory bowel disease, we give a small bowel follow-through, and here's that area of thickening in the terminal ileum, but it's only a luminal contrast there. So jump forward, here is CT enterography. Now we can actually see the wall, the inflammation, and the mucosa, as well as the inflammation and mesenteric edema associated with that. But there is a radiation penalty, of course. Skip forward in time, still qualitative, but beautifully qualitative. Here's an MR enterogram showing the fluid-filled bowel, the valvulae convenientes, but this area of luminal thickening as well as narrowing, and the ileocecal valve using MR enterography. You saw very quickly that video that Dr. Bulas showed with the peristaltic action of the bowel. What if you could actually quantify that peristalsis there? This is a vector diagram produced by our quantitative imaging lab, where you can actually see the motion and peristalsis and quantify that information, which is why now we can create these peristaltic maps of the bowel, and basically red is fast, blue is slow, normal bowel peristalting will be kind of yellowish and greenish, hypoperistaltic, inflamed, thickening, or scar bowel will be bluish. Allow us to see these areas of thickened bowel, skip lesions, and in the very near future, response to therapy. If it recovers peristaltic action, if it's responding to therapy there, it'll get progressively warmer and more peristaltic. Let me talk about augmented reality, and this is not Dr. Raj Shekhar. He showed this. You can talk about augmented reality forever, but the best way is to give a real-life analogy. What is missing from this picture? Where's the line of scrimmage? Where's the first yard line, right? We now expect to see that. This is augmented reality where something is so natural, so helpful. Where am I? Where do I need to go? Give me that information. This is so intuitive and natural that you actually miss it. But guess what? It's not there. It's an augmented version of reality. This is laparoscopic cholecystectomy. So this is how our wonderful surgeons operate, and they're doing a great job there. But boy, it's hard to know what's underneath there, right? Where's the hepatic artery? Where's the cystic duct? Where's the tumor? Where's the stone? Which is why it is so interesting now that we can actually superimpose ultrasound images. So rather than looking at it on a screen on the wall or on a sheet of film printed on a light box, there's the hepatic artery and there's the cystic duct. Alternatively, if you're looking for a gallstone, why guess where it is when you can actually see it superimposed, augmented reality? There's a stone to guide our surgeons for safe as well as efficient surgery. Let's talk about MR-guided robotics. And this is not at Dr. Cleary's lab, who was really pioneering MR-guided robotics there. The first time I was learning how to do arthrography, the person had been doing this for 20 years, inserted the needle, injected the contrast, and it flooded the surrounding soft tissues. He had missed. I'm thinking to myself, gosh, this person's been doing this for 20-plus years. What chance do I have, and how did he miss? And the reason he missed, of course, is he's going on two-dimensional landmarks on a planar radiograph. Wouldn't it be great if you could actually see the structures, see the joint space, see the labrum, see the capsule, see the surrounding vessels there? Well, this is an MR image, so wouldn't it be great, of course, to do these under MR guidance? What's the problem? The problem is the bore of the magnet is this tight, tiny, claustrophobic tunnel. The patient barely fits in that tunnel. So Dr. Sharma's ability to reach in there, and he's lying on his belly, his head's in the bore, he's desperately looking over his right shoulder trying to see what's happening on the other side of the room. What are the chances of this being a usable alternative? Well, our answer to this is to create a robot that goes into the bore with the patient. Just for orientation, here's the patient's shoulder on a mannequin. Here's the neck there. This robot is perched on the shoulder, and it is your virtual telepresence in the bore of the magnet. You control it from the side there. You see the soft tissues. You see the capsule. You don't miss, and you don't use ionizing radiation. Lastly, I'm going to talk about molecular imaging. If you read the literature, the definitions of molecular imaging tend to be multiple paragraphs long with multisyllabic words, which frankly are very hard to follow. I'll give you my very, very simple approach to understanding what molecular imaging is. In the short version, it's imaging biology. Most of what we do in radiology is imaging anatomy, and there's certainly nothing wrong with this. Where is it? How big is it? Does it have calcium? Is there a tumor in the posterior fossa of this patient? If you're imaging physiology, we're talking about largely functional MR. We're not talking about anatomy now. We're talking about perfusion maps translate into images, bold images of the brain. So this is not an anatomic map. This is a perfusion map of blood delivery to this hypervascular tumor occupying the right parietal brain. On the other hand, if you're actually trying to find out, does this tumor have a specific receptor that distinguishes from a tumor that doesn't have that receptor, you're imaging biology. It's not how big it is. It's not, does it have blood flow? Does it have this receptor and not this one? Will it take it up there? Will it help us plan the specific biological treatment plan for the specific brain tumor? If you're imaging biology, you are doing molecular imaging. Examples of this, gene delivery, the liver gene expressed in the left flank of this mouse, that is gene delivery visualized optically. You can't do this using prior quantitative and physiologic image. Is there receptor uptake? This is a probe that binds to the HER2/neu receptor, which has a prognostic significance for breast cancers. If the tumor has the HER2/neu receptor, it will enhance. If it doesn't, it won't. This is a non-invasive imaging biopsy of this tumor without sampling error. And lastly, neoangiogenesis. A lot of tumors need to create new blood vessels to survive. A lot of our new therapies are trying to turn that off there. The ability to non-invasively detect the development of new vessels and to see the successful turn-off on those vessels is the promise of molecular imaging targeted neoangiogenesis. Let me give you one example of a paradigm we're trying to change upstairs in a lab led by Dr. Rohan Fernandez. This is state-of-the-art for brain tumor diagnosis. Do an open biopsy. If it needs to be resected, there's a relatively large resection cavity, but it's hard to know the margins of this tumor because it blends in with surrounding normal brain there. Hence the need for adjuvant chemotherapy and radiation therapy. Survival has improved dramatically, but there are often terrible neurocognitive consequences. So our vision, Dr. Fernandez leading this lab, is to develop Tumor Paint. This is this Prussian blue manganese incorporated contrast agent with a specific ligand that will bind to a receptor upregulated in specific tumors there. And you can see in his mouse model, there it is glowing. The vision in the future, the surgeon does his procedure. He or she thinks they're done, then they dim the lights, turn on the fluorescent light. Any residual tumor that needs to further resected will glow. And perhaps that will allow us to tone down or even eliminate the adjuvant chemo and radiation therapy. And lastly, drug-eluting beads. I'm just going to start this animation, but these are beads that contain chemotherapy. They have specific ligands to them. They're delivered by the interventional radiologist. They flood the tumor, bind to it, and now as these drugs elute out there, there are at least 3 distinct targets for these beads. First and foremost, why not snip and destroy the DNA? Mitochondria, why not kind of cause that tumor to run out of gas by disrupting its energy source? Lastly, why not puncture the cell membrane or the nuclear membrane cell like an overripe balloon and basically destroy that cell and preserve the surrounding normal tissues? This sounds like science fiction, but these are images provided by Dr. Sharma, who is doing this right now as we talk. A liver tumor in the medial segment of the left hepatic lobe, angiographic delivered tumor-eluting beads, and the successful incorporation, sorry about that. Should this be in the front there, you'd actually see the imageable beads kind of impregnating this tumor and eluting that therapy there. So in summary, in terms of the future of pediatric radiology, both at children's and beyond, we are creating environments that heal and enhance the experience of patients and staff. We are developing operations that are safe, meaningful, and valuable, and we are pioneering, inventing technologies that improve the diagnosis and treatment of children. I'm going to finish where Dr. Bulas started off, which is a picture of William Conrad Röntgen, now an old man, incredibly humble. Hated it when people called the Röntgen ray, please call the X-ray. Never patented it, didn't want a penny from this, was just proud and humble to know that his invention and discovery had made a difference in medicine. And one of my favorite quotes by John Ruskin, the greatest thing a human soul ever does in this world is to see something. To see clearly is poetry, prophecy, and religion all in one. I'm not so bold as to say we radiologists are poets, prophets, and priests, but I will say we are passionate about seeing our patients more and more clearly every year and working using this vision to help our wonderful colleagues help take care of our patients in a way that is safe and non-invasive. Thank you so much for your time and attention. I think we have 10 minutes for questions, and I was asked to make a shout out to those on the WebEx, so please also call in. We would welcome and be appreciative of your questions.
Ray and Dorothy, thank you for an excellent talk. It was so interesting. I just wondered if you could comment in terms of all this exciting technology and how this should impact how we are training our students, residents, and fellows, particularly with respect to physical diagnosis.
Oh, what a great question. I'll give it a first shot, and then I'll turn it to Dr. Bulas there. I used to teach physical diagnosis, so I'm a huge believer in the art and science of that, the laying on of hands there. I believe radiology should supplement and enhance our physical diagnostic skills there. Those who haven't should see Dr. Abraham Verghese's talk, The Next Great Innovation in Surgery, which, by the way, is a surgeon's hand there. First and foremost, I think all residents and fellows who are not studying radiology should get more formal training in the power as well as the utility of diagnostic imaging. But I think there needs to be greater cohesion between the imaging findings and the direct physical diagnostics there.
I do think that, well, one, for anatomy, I think there should be a pretty big presence with, I know at some centers, the cadavers also get CTs done on them as well. So they're learning from the CT as well as their own cadavers. There are some medical schools that have pretty aggressive ultrasound training, even in the first and second years. I think that will continue to escalate with time. Whether ultrasound will truly be the stethoscope in the future, I'm not sure, but I think because it is so small, so compact, and so inexpensive, certainly for some areas of physical diagnosis, it will become partial, to it. But it's not easy, and for everyone to at least be more aware of what's available and what the future is, that has to be part of the training as well.
I also thought that was just a beautiful lecture you both gave. Thank you so much. It was exciting and beautifully presented. Can you talk a little bit about the finances of all of this, the costs of the machinery, the costs of doing the equipment, and as we move to a value-based system that Dr. Cora Bramble is leading, how do you see that affecting the future of radiology?
Yeah, that's a fantastic question there. Our typical imaging equipment is in the hundreds of thousands to millions of dollars there. It is a challenging situation. Right now, the way medical reimbursement works, we meet and exceed our margin every year there because we're able, given the cost structure, to charge quite a bit for our imaging studies there. It would only take a change in Congress and the way things are reimbursed to completely threaten that model there. I guess my other answer to that question is I don't believe that some of the things that are incorporated in imaging are absolutely necessary. I've often talked about the imaging arms race there. On one level, I'm fascinated by incorporating very, very low-cost imaging to expand our reach, advanced diagnostic imaging, without costing quite as much there. Some of it's necessary given the research technology, but I do believe that we can embark on an era of low-cost imaging that is equally effective.
I did want to again do a shout out about the outreach issues, because if we have like 1 billion children who don't have any medical imaging, how do we get it to them in a cost-effective way? So I do think ultrasound is in a very exciting area because not only is it low cost, one of the biggest issues with outreach is these machines break. Then we can get donations, but then we don't have the capability of maintaining them. And many of the countries I've gone to, I've said, they've told me, there's a CT, there's an MR, there's an ultrasound. I get there and everything is broken and nothing is maintained. So, as we push forward with outreach in radiology, we have engineers who are trying to construct X-ray machines that can endure 80% humidity and don't have really very exotic fine mechanisms that they can really endure moving and transporting and getting the electricity that invariably will shut down to work. So I think there's some very exciting advances that we're doing, but I think as a society we have to also be able to say we do need to have these modalities available to lower income areas as well, because the level of medicine dramatically changes once you have pathology, once you have radiology, but it has to be done less expensively.
Ray, can you share with us your plan for controlling quality in the era that Dorothy showed, where every emerging medical student or resident or faculty can plug a transducer into their iPhone?
Oh. How much time do you have for that answer? I am pleased to say I'm working with Dr. Bulas as well as members of the ED, including Dr. Joanna Cohen and Alyssa Abo, to basically try and tame the Wild West. At this point in time, given the low threshold for requiring ultrasound, pretty much anyone can get one. And guess what? It's not as easy as it looks. I liken it to playing a musical instrument. No one would believe they could go to a weekend course and come back being able to master the cello or the flute, right? And yet somehow there's an idea that if I go to a weekend course on ultrasound, suddenly I have my certificate and I can do it competently. The stakes are embarrassment with your cello and flute. They could be life and death with an ultrasound there. We're trying to reach out. We're creating an oversight committee to invest in both training, in terms of QA, in terms of archiving and accountability of our reports there, and ultimately, of course, billing. So the short answer to your question is we are working very, very diligent with multiple stakeholders and divisions throughout who are interested in technology, but we want to make sure it's done right. Its availability is also its threat and danger.
Can I have the last word?
Yes, please.
Back to Dr. Batshaw's question. I think we have to continue to learn to live in two worlds. The one world of being a leader in innovation, creativity, and pushing the envelope of new treatments, new therapies, new diagnosis. And that can be expensive. It means research. It means having the best quality, but it means breakthroughs that ultimately save lives and probably in many ways can lead to decreasing costs. And you look at a lot of the technologies that you've shown to solve something once right the first time. Maybe it's a technique that used to require 5 operations that now is done with an interventional technique. And we have to, I think, do a better job of quantifying that quality, or having your neuroradiologist diagnose something on one, super good MR is a lot better than 4 or 5 different ones done in the community that are wrong and lead to misdiagnosis. And we have got to be better at assessing that. But I don't think we want to use the excuse of population health value-based care to back off of our role and responsibility as a leader in pediatric innovation. That's one thing. The other is that I think there are lessons to be learned in what Dorothy's talking about in terms of trying to find ways of spreading technology and diagnosis. And it is and I know you're concerned about the disruption of innovation, but it's inevitable. And there will be all of these people with all of these devices. And it may help the rest of the world. We need to find ways of employing that disruption thoughtfully and taking advantage of it in the value-based healthcare. So I think it's a great time to be in these fields. It's a great time to be at Children's National. When you look at the merging of some of the disciplines of surgery, biomedical engineering, and radiology, and you can't even tell who's who anymore. So anyway, thank you for bringing all of this to us. Congratulations on your birthday, and we look forward to. Do you want us to sing "Happy Birthday" to you?
No.
But we look forward to many more, and thank you for your leadership.
Thank you.